Thank you for joining me today from wherever you are in the world. I understand there are many countries joining this presentation. So wherever you are, I do hope that you'll find there is something in today's presentation that you can take back to your practice and use when you are fitting Rose-K lenses. Rose-K has become the most widely used design in the world, now sold in over 90 countries. And you have to ask yourself, why has this happened? There are so many irregular cornea designs. Why has this design been adopted by so many fitters around the world? When I started fitting the irregular cornea back in the 1970s, you had to really be an expert. It required high levels of skill. You had many different trial sets. You often had to do in-house alterations on the lens, so you had an alteration kit within your practice. It typically resulted in 3 or 4 lenses per eye, very time consuming, not cost effective for either the laboratory, the patient, or for me, and typically resulted in experts in each city because people just didn't want to fit the irregular cornea. So I decided there had to be a better way. So what was my reason for designing Rose-K? Basically to try and simplify the fitting of irregular corneas. I wanted to enable every GP fitter to be able to fit the irregular cornea with reasonable success. When I started off, we used to have, I probably had at least 12 different designs of irregular cornea designs in my practice. You had to state the back optic zone, you had to state the secondary curves and widths. Typically, you often have large over-refractions because the trial lenses were often low minus lenses, so you could end up with minus 20 as your over-refraction. So when the lens came back, power was never right and it was thicker, so it behaved differently than the trial lens. And as I mentioned, you had this very, very high reorder rate. So I decided to take out the things that made fitting quite difficult. I decided to take out the back optic zone, you could not state that, and also to take out the secondary curves and widths. I would actually set those for any stage of the disease. And also to make the trial lens as close as possible in power to the final RX lens. Also, it's quite difficult to teach how to fit keratoconus. To say to somebody looking at a fluorescent pattern, change the third curve, go 0.2 wider and 0.5 flatter, really doesn't mean a lot to the inexperienced fitter. So I decided to come up with a fitting system, a 5-step fitting system that assisted you in the process of fitting and which would give a good result to the majority of fits. So can one design fit all types of irregular cornea? Unfortunately not. And as you see on the screen here, I started off in 1990 when the lens became first available in New Zealand, and that was my keratoconic design for the oval cone. But subsequently, over the years, I've had different designs addressing different types of irregular corneas. And more recently, in 2016, we introduced the Rose-K2 Soft, which typically is for early cases and for those patients which cannot or do not want to tolerate a rigid lens at all. So with 6 Rose-K designs now available, you should be able to fit nearly all cases of the irregular cornea from one of the Rose-K2 designs. But it is very important to understand which designs are used for which condition. So when you're ordering the Rose-K designs, what parameters do you state? You obviously state the design you want, one of those 6 designs, the base curve, the edge lift value, the diameter, and the power. We can identify typically 5 distinct groups of irregular cornea, and although some of them overlap a little bit, experts tend to agree there are these 5 different separate groups, with the most common being the oval cone and the least common being keratoglobus. So I'm just going to take a moment to analyze these 5 different categories. Sorry about that, my screen froze for a moment there. So if you have one of these 2 conditions, either oval cone or nipple cone, you're going to use one of these two designs, either the keratoconus design, my original design, or the nipple cone design here. However, if you have larger areas of distortion, such as you see in this right-hand side, typically these small lenses that you use on these conditions are not stable and do not fit conditions such as pellucid or globus very successfully at all. You need either a larger corneal lens or you need to go to a semi-scleral lens like Rose K2 XL, which is a corneal scleral lens. The XL design can be used on any of these conditions, even a nipple cone. I've seen it very successfully used on very small areas of distortion, corneal distortion. So feel free to use the XL in any of these conditions, but again, it's not my first choice if I can fit a corneal lens and get a successful result. So looking at this more detail, nipple cones represent about 5 to 10% of cones that you see. The average or standard nipple cone is only 8.3 millimeters, a very small lens, although you have a large range of diameters that you can go up to. So typically, if you have the type of fluorescent pattern that you see here, a very, very steep central small cone, your first choice would be to use the nipple cone design. Also, the secondary indication for this design is for very, very advanced cones. So if you have, in this case here, a very early oval cone, the nipple cone could also be used in that case. Moving over to the oval cone here, so the primary indication for the lens design for this condition is Rose K2 KC. I put KC there because although it's only called Rose K2, it just distinguishes it from the other designs. Secondary indications, if you get a very, very steep oval cone, the NC design may be applicable. If you get a very, very discentered oval cone, the post-graft lens may be indicated for the oval cone. Moving on to the post-graft design, which has quite a lot of reverse geometry, try to accommodate the particular oblate shapes as you see here. So your design for any post-surgical condition that includes grafts, ectasia, and rings is the post-graft design, Rose K2 PG. However, for this condition, if that lens doesn't work, the slightly larger lens, which occupies and sits on most of the cornea, 11.2 or 11.4, depending on where you are in the world, is the standard diameter for the IC design. And if all that fails, then move to the XL design. For pellucid, you notice here I state XL as my primary first choice. Pellucid is very difficult to fit within the cornea unless it's a very early pellucid case. And in some cases, in early pellucid, you can also use the IC or PG design. In globus, again, I would move immediately to the XL design. To get globus fitting with a corneal design, it is indeed challenging. So here's the first question I'm going to pose to you. What are the two most commonly confused conditions? As I travel around the world, I often get presented with a map and they'll state what particular this condition is. I look at the map and say, that's not that condition. And it's very important to understand the condition you're fitting, as it's going to influence the Rose K design that you use. So I'll just give you a moment to think about that. What are the two most commonly confused conditions? So in my experience, they are the oval cone and pellucid marginal degeneration. Typically, if you get a very low, large oval cone, it can be confused with pellucid, but there are some factors which make these two easily distinguishable, and I'm going to cover that now. Oval cones are by far the most common type of irregular cornea. About 65% of all the irregular cornea you deal with are oval cones, and it represents about 90% of the cones you can see. It's commonly descended down, as you can see here, about 1 to 2 millimeters below the visual axis. It's 5 to 6 millimeters in diameter. It is not as steeply curved as nipple cones. And the things I've outlined in red or in pink here are the distinguishing factors, particularly so you can distinguish it easily from pellucid. The Ks are normally steeper than 8.0 in the flattest meridian, whereas in pellucid they are very commonly flatter than 8.0. The actual cone does not extend out to the limbus, so you have some bearing of normal cornea between the lower edge of the cone and the limbus, where in pellucid the actual steepening occurs right down to the limbal margin. And very importantly, oval keratoconus has often withdrawal astigmatism associated with it. So that means the lens is going to actually bear in the horizontal meridian more so than the vertical meridian. If we move to pellucid, and again I'll just move to these 3 points that I've highlighted which distinguish it from a cone. The difference with pellucid is you have high amounts of against the wall astigmatism. So this means that if you place a lens on the cornea, you will find it will look tight, will bear at 90 and 270, whereas with keratoconus it bears horizontally at 0 and 180. And very, very frequently you have these curves that are in one meridian flattened at 8.0. Also, if you look at the diagram here, the actual steepening and thinning occurs right up to the limbal margin, where in oval keratoconus that is not the case at all. So it's very difficult to try to fit pellucid with a corneal lens. Why? This is the way we used to fit pellucid before we had the advent of these larger lenses. We had to leave the lens flat, as you can see here. If you in fact fitted this area here, the lens simply descended down and was not successful. So you often ended up with staining over this area you had to accept. Not ideal, and you often had areas like this. It would ride off onto the lower lid and be very unstable. By going to a larger lens, you can vault over all that. You can see the landing zone of XL is just inside the limbus here, and it just shows very, very light angle touch, but you get a very, very much more stable result. So if you identify pellucid, I will go immediately now to the XL design rather than to try to fit it with a corneal design. If you look at the asymmetry in this video, how are you going to fit that with a corneal design? You have so much against the rule astigmatism, with the lens lifting off at 0 and 180 and bearing quite tight in the vertical meridian at 90 and 270. Just about impossible to fit with a corneal lens. Also, in some cases, no matter what you do, the lid structure or the descented cone means the corneal lens descends down. This causes poor vision and often long-term causes injection in the lower parts of the conjunctiva. If you go to a lens like XL, you immediately see the lens will center well. Decentration is basically non-existent with XL, so you don't have to worry about a lens decentering down as you see here on the left picture. Also for grafts, corneal lens will always center towards the highest point on the cornea. So if the highest point is along the graft-host interface, which is so often the case, the lens will decenter out, as you see here, to this point. This will impact into the limbus, make the lens less comfortable, and make it more unstable. You can see here it's lifting off. So in grafts, again, if you have these high areas and you have decentration problems, XL would be my choice if you can't resolve it with a corneal lens. I want to take a moment to talk about topographies. These are the sorts of maps I get presented with when I travel around the world. And my first question to a person is, well, what are the settings on your topographer? Because these maps are not telling me much about the shape of the cornea. So if you bring up maps binocularly, the actual scale chosen will cover both maps by the topographer, and it defaults to something called the absolute or standard scale. Now, this scale may not be relevant to the actual map you're looking at. So the scale here only goes from 9.38 to 6.75 millimeters, which means that anything steeper than 6.75 will be represented in a single color. So is this pellucid? Is it Clovis? Is it an oval cone? Is it possible to tell? However, if we use the normalized scale, immediately we can understand this corneal shape much better. This map and this map are exactly the same map. The only difference is the scale that I have used on the topographer. And this is used the normalized scale, this is used the standard scale. So here the scale, in fact, goes up much higher. So with the standard scale, it uses a set scale and it can skew the color range and mask the actual details of the cornea. With the normalized scale, only uses the shapes from the flattest to the steepest values, and therefore is going to be much, much better for the shape of the cornea that you're looking at. So if we look at here, absolute on the left, normalized on the right, and you can see the difference. Even though these are exactly the same maps, all I've done is change the scale, and you can see how it affects the look of the actual map that you're viewing. Here we have another factor which can influence the map, and that is whether you choose the tangential or the axial setting. Tangential talks about tangents to the cornea, so it talks about shape of the cornea at any point. Axial talks about the actual power of the cornea. My preference is axial, although some people around the world, my preference is tangential, although some people around the world actually prefer axial. I think when I'm trying to analyze what type of lens, I want to know the shape of the cornea rather than the power. So understanding the difference, axial maps tend to exaggerate the decentration of the cone and the base size of the cone. So here's another example of a tangential versus an axial map. So my preference to determine the corneal shape, I like the normalized setting, tangential setting, curvature, and always view the maps monocularly. If you view them binocularly, the topographer has to use a much bigger scale if the two eyes are very different, as often is the case with keratoconics. However, if I want to actually understand where the lens will bear on the cornea, the elevation map provides very, very useful information, because the steepest point on the cornea does not necessarily equal the highest point. So what do I mean there? If we look at this particular topography, if I said to you, if I placed the lens on that cornea, where's it likely to bear? I would say the majority of you would say, well, that's going to bear right in the central area here. This is a nipple cone or something similar. However, if I use the standard elevation map, I see that this, in fact, is not actually the highest point. It's just a little island in the middle of a flattened area. So in this case, this was a graph of ectasia. So this is not actually the highest point. It's just an island in the middle. It might be the steepest, but it's not the highest. So the elevation map is very, very useful in determining where the lens will bear. And that's quite useful also, particularly when you go to bigger lenses like XL. So if we place a lens on this cornea, we immediately see the bearing is not centrally here, but is actually in the periphery where the highest point on the cornea is. So topographers, in summary, are useful for judging the central fit, not as reliable for peripheral fit, as often the maps are not as accurate as you get out to the 5 and 7 millimeter circles. Not useful in selecting the appropriate diameter for what lens you're going to fit, and have no application for power or movement. So they don't replace putting a trial lens on an eye. So where do you begin? Identify the condition you're thinking you're going to fit, choose the appropriate design, and follow the 5-step fitting system. So I'm going to talk today, the time allows to talk only about one type of design, so I'm going to use the keratoconics lens as an example, because for all the corneal lens systems, the system of fitting is exactly the same. So where I'm talking about the keratoconic design or the nipple cone design, we use exactly the same process. So today I'm going to be referring to the keratochronic design. So I talked about a 5-step fitting system, and you can see here, this is the system, and this is the order you approach the fitting under. You start with the central fit, move to the peripheral fit, the diameter, location, and finally the lens movement. And once you become familiar with my designs, you should expect to achieve at least an 80% success rate. There's been many studies done on my designs worldwide to support that. Once you become familiar with the design, that's the expectation that at least 4 out of 5 lenses of the first ordered lens will be successful. But let's start with the central fit. Each design has its own rules for choosing the trial lens, and it's based on either K readings or your topography readings. We take the keratoconus lens as an example. You can see here that for flatter corneas, you actually have to go steeper than the mean K. But for very steep corneas, it becomes a little less predictable, but you actually have to go flatter than the mean Ks. So there are guides which will help you and guide you to select that first trial lens. So what are we trying to achieve? The video on the right here shows what we are trying to achieve, what I describe as light feather touch over the highest point of the cornea. And with cones, it's usually slightly centered down, with the oval cone slightly centered down from the center of the pupil here. This is getting too steep here, and we don't see any touch. And this is getting a little bit too flat by about 0.1 to 0.2. We're showing too much bearing over that highest area. So you're going to basically vary the base curve up and down until you see this light feather touch in the right-hand video here. So how do we know we have feather touch? If you think, have I got feather touch, or should I go a little bit flatter or steeper? If you go 0.1 steeper, you should see no touch, because depending on the base curve that you're fitting, but roughly in my designs, going 1.1 steeper will change the tear film and make it deeper by about 20 to 30 microns. Topographers recognize that when we talk about feather touch, we don't actually have touch. We still have about 20 to 30 microns of clearance. So you can see this as a simulated map produced by the Ledmont topographer. You can see here we're showing cut. So this point here, where the cursor is represented here. And if you go along the scale, you see we still have around 25 microns of tear film, even though we do not show fluorescence. You need at least 25 to 35 microns, in my opinion, of fluorescence to actually get fluorescence. So when we're talking about feather touch, we don't actually have touch. We still have around 20 to 25 microns of tear film at that point. The lens will always settle back further on the cornea the longer you leave it there, so you should leave it until the lens settles, at least 60 seconds. I like to use anesthetics if you're able to. It just shortens the time and makes it more comfortable for the patient. Also, it's very important that you locate the lens correctly. You can use the lower lid margin to do that. You should only assess the fluorescent pattern with the lens centralized over the pupil. You can see here this looks like the lens is pooling, and the reason is if the lens lags down, it will often pull inferiorly. If it actually locates high, it will pull superiorly. So it's important to locate the lens centrally over the pupil. And here, avoid epithelial staining. If you leave a lens flat, a patient comes back and this is what you see. This is exactly what you do not want. You want to avoid that at all costs, because it will lead to this sort of circular ring staining you see on the right, and eventually that leads to scar tissue in the upper 1/3 of the stroma. So be aware if you see staining over the apex, it's an absolute sign that you need to change something. The tips for central fit: the lens should stay on the eye for a minimum of 60 seconds with the patient looking straight ahead. Lens must be centralized, and judge the fluorescent pattern directly after the blink. That's the most accurate time to do it. Also, try to view it with the patient's head in a natural position. Often a slit lamp gives you an artificial head position, and it can change the way the lens sits on. So if you do have a lamp where you don't have to put behind a slit lamp, that can be useful in interpreting the fluorescent pattern. And always use a blue filter, very important. It gives you a much better idea of interpreting the fluorescent pattern. So let's now move to the peripheral fit. So this is what's happening at the edge of the lens here. So in that last sort of millimeter, 1.5 millimeters, we're now going to see the importance of this area. So when you change the edge lift, and you have multiple choices in rows A, you're going to change all the curves from the edge of the optic zone out to the edge of the lens. So even though you're only interpreting the fluorescent pattern in the last 1 to 1.5 millimeters, we actually are changing all the curves from the edge of the back optic right out to the edge of the lens. What are we trying to achieve? We're trying to achieve a fluorescent band at the edge of the lens, 0.6 to 0.8 millimeters wide. And that is what you see here. This is between 0.6 to 0.8 millimeters wide. Very often you'll have a little bit less width on the nasal cornea, because often the nasal cornea is flatter than the temporal cornea. If that's the case, you simply average the two. Again, the lens must be centralized. So the left one shows excessive lift. That's getting about 1.5 millimeters. That lens would be unstable on the eye. And on the right, the picture, that lens shows a very, very tight edge lift. We're going to have to increase that edge lift. That would be a most uncomfortable lens and probably would bind onto the cornea. So this is an ideal looking peripheral fit. Not too often you get one that looks this good in all meridians, but this is absolutely ideal. You have a scale which allows you to alter the edge lift either more or less. So if we take the keratoconus lens, you have a edge lift values from -1.5, which means you can reduce the edge lift on this side of the scale, or up to +3, which means the edge lift is much, much higher. So the standard lift, which is most of the trial lenses, unless you particularly want a different lift trial set, it fits about 60% of the normal oval cones. You'll require the increased lift in about 20%, the decreased lift in about 15%. So what does all that mean as far as fluorescent patterns goes? If you put the standard lift, and all these pictures are with a standard lift diagnostic lens, if you put that on the eye and this is what you see, this pattern is completely acceptable, even though it's a little bit asymmetric on the nasal and temple. You would simply order zero lift or a standard lift. If this is the pattern you see here when you put the standard lift trial lens on, this is much too tight, you're going to have to order the standard increased lift to achieve this pattern here. This is getting grossly tight in the periphery. You would need a +3 lift to achieve this pattern. And similarly, as we go to the decreased size, if this is what you see with your standard lift, this is too much lift, you're going to have to order a 0.5 decreased lift, and over here you're going to have to order a -1.5 decreased lift. The amount of flattening across the back surface of the lens is now defined by a single number, which I call edge lift, rather than by stipulating optic zones, diameters, and technically curved radius and width. Makes it much easier to control what is happening in that peripheral part of the lens. So looking at a few more videos here, the one on the left shows a very, very tight lift, very, very tight edge. This is optimum, and this is getting too loose. And when the edge lift gets too loose, the lens becomes very mobile, and you'll often see bubbles starting to appear at the edge of the tear meniscus, as you see at about 270 there. So here you can see that the edge lift is excessive, it's getting bubbles, the tear meniscus is breaking away, and again here the edge lift is excessive, and you can see the bubble formation at 270 in that video. Again, these two are excessive. Just simply by ordering the standard decrease lift, which is minus 0.5, you would immediately, in fact, improve that and change that width back to between 0.6 and 0.8 millimeters. And this is getting grossly excessive. You're going to have to change it by about 1.3. This is about double. This is probably getting about 1.5 millimeters. So you're going to have to make a large change to that peripheral fitting. Here we see cases where it's too tight, and you can see the damage this is causing to the epithelium. This is actually probably binding to the cornea. This patient could only wear this rose-K lens for about 2 hours before it became uncomfortable. All I did was alter the edge lift by plus 1.5, and wearing time went all day. The edge lift value was just so important in determining how that lens will perform. And when you get to this is extremely tight. This is a normal Rose K2 lens on a nipple cone, and it shows the edge being excessively tight. These tears are never going to exchange here. This is going to be a most unsuccessful fit. But what I advocate now with a design something like this is using the NC design, which would suit this corneal shape much better than the keratoconic design. So tips for central fit: alter the edge lift to achieve that nice band of fluorescence as you see below there. Judge it in the horizontal meridian. The reason we do that is because that usually is the flattest part of the cornea, and that's where the edge lift is the tightest. The lens must be centralized. The best time to judge it is immediately after the blink, with the patient looking straight ahead. So in my opinion, peripheral fit is the singularly most important factor for a successful, comfortable fit. You can be slightly out with your central fit being slightly flat or slightly steep, but if you don't get the peripheral fit correct, the lens will not perform optimally. So question 2, what edge lift would you order here? I hope we all agree that this shows an excessively tight lift, and you have several options here. This is the lens that came back from the laboratory. Again, I look at this and I say, I probably underestimated it slightly. The patient was able to wear this lens quite successfully, but I probably underestimated the lift. What was the lift I ordered? It was a plus 1.3. What I should have ordered was a plus 1.5. So that gives you an idea of how much the edge lift pattern changes when you change the edge lift. So question 3, how would you improve this fit? I hope we all agree that this lens looks very, very tight in the periphery. It is also sitting down. If you make a lens very tight in the periphery, it will tend to locate low. This is actual touch here, and these are bubbles here. Here's the lens that came back from the laboratory, and you just see what a difference there is in those fluorescent pattern. We have a lovely band of fluorescent, about 0.65 wide at the edge there, absolutely perfect. What edge lift did I use? I give you a choice of edge lifts again. It was a 1.5 again there. And you can just see by changing the edge lift how you dramatically change the pattern at the edge of the lens. Always use a yellow rattan filter. I purposely haven't used one here just to show you how much more difficult it is to interpret the fluorescent pattern. So always use a yellow filter. It takes out the excessive blue light. Let's move on to the overall diameter. Each lens has standard diameters, which I've highlighted in that red color through the middle there, although you have a wide range of diameters within each design. For example, in the keratoconic design, you can have it as small as 7.9 and as large as 10.4. The XL design, which I'm not talking about today, the standard diameter is 14.6, but again, you have a large range of diameters from 13.6 to 16. For the keratoconic design, what we're trying to do is just hang it off the top lid. We want to try to use the minimum diameter to achieve good location. No use going excessively large like this. This will tend to impinge on either the limbus at the upper or lower regions. So you use the minimum diameter which gives you good location. So the most used diameter worldwide is 8.7 for the keratoconic lens, but in Japan it's a little bit less than that, it's 8.5. The horizontal visible iris diameters are less there, and in Italy where you have these large eyes, the most used diameter is 9.0. So depending on where you are in the world depends on the diameter that you may find is going to be your standard diameter. One other thing to consider is the position of the cone. If the cone is central, you can get away with using a small lens, but as the cone moves further and further away, you have to consider going larger with your lens. Why? The lens will always descend to the highest point of the cornea, as I mentioned before. If we try to fit this cornea here, I'll just go back a step there, and you can see the cone down here in that area. It's very, very decentered. If we try to fit that with a very small lens, the lens is going to sit down over here and not give us a good fit or good vision. So the further away the apex of the cone is from the visual axis, the bigger the lens needs to be. So with a nipple cone, which tends to be just about central, with usually very, very central small cone, you can get away with a very small diameter and the lens locates very, very well. The diameter is important. Typically, you read larger diameters, the wider the palpebral aperture, and for early keratoconics, and small diameters in advanced keratoconus or smaller cones. And your trial sets will reflect that. You'll notice that I have made steeper base curves in the trial set in smaller diameters and flatter base curves in larger diameters. That's in the keratoconus trial set. And the larger the area of the corner distortion, the bigger the lens needs to be. So next is location. What controls location? Three factors control location: base curve, diameter, and edge lift. So often we see with keratoconics the lens descends down, as you see here. The reason why is because the cone apex is descended down. So if the lens is descended down, what do? We can increase the edge lift, make it bigger, or flatten the base curve, or any combination of those will assist the lens to ride up. So here we have a very, very large flat lens, and you can see how it's tucked under the top lid. We have a lot of lid attachment, and that causes the lens to ride high. This video I used to show the importance of how a base curve change and the edge lift change can alter the lens location. In this left video, you can see how the lens constantly wants to sit down. And we can see these little bubbles within the optic area, which suggests we might be a bit steep. We appear to have light feather touch, but not much touch at all. So in the next video, I've gone 0.2 flatter, slightly larger because that's what the trial set automatically did. And I've changed my edge lift from standard edge lift, which is quite narrow here, to the increased, and you can see the difference. So let's have a look how this lens now locates. Simply by flattening the base curve and increasing the edge lift, the lens performs completely differently, and this will be a much, much better lens than the steeper base curve with the tighter edge lift that you see on the left. Here we have excessive edge lift, as you can see here, and immediately, even though the lens is flat, you can see the base curve is flat, which is also making it ride higher. You can see here the excessive edge lift. All I did was reduce it by 0.7, and even though the lens is still flat, you can immediately see how the lens is decentering down. So by changing the edge lift there, I have immediately altered the location of the lens. Also, I mentioned base curve. In these cases, you can see this is the flattest base curve. The lens is here, the steepest, and these two are in between. So this flat one, the lens is right in the highest, the steepest, the lowest, and these two locate fairly well. But look at the difference in the edge lift pattern. Even though all these pictures are on the same eye with a standard lift trial lens, just look how much the edge pattern varies. So the importance of that is here we have excessive lift, we don't have sufficient, we have quite a nice result here and here. So as you steepen your base curve, it will change your edge lift pattern and it will reduce the fluorescent band you see. So you cannot judge both the base curve and the edge lift together. Always get your base curve correct before you consider the peripheral fit. And finally, the lens movement. Lens movement is mainly controlled by the edge lift value. And here you can see ideal amount of movement. That's going to ensure that we're going to get good tear exchange underneath that central part of the lens, so we keep the particular area over that cone well replaced with fresh tears. So here in these videos, and I'll just go back one there, what I'm going to do here is this shows optimum movement. In the next video, I've tightened the edge lift slightly, and immediately you see the movement is slightly less, and we have less lid attachment. Let's move now to the right video. So here we have basically no edge lift, just about no movement, and just about no lid attachment. This lens would very most likely bind after a few hours to the cornea. So just by changing that edge lift value, I can change exactly how the lens moves. So tips for lens movement, you're trying to achieve 1 to 2 millimeters. To increase it, you increase your edge lift. To decrease it, you decrease it. And increasing the diameter can in some cases reduce the movement, but not necessarily so. Tight lids require less lift. So if you're fitting, for example, an Asian eye with tight lids, you may have to shut the edge lift pattern down more than what you would consider an optimum edge lift pattern. And for example, if you have very loose lids, you may have to open the edge lift up away from the optimum pattern to achieve sufficient movement. So just to finish up, some general fits. What is the main problem with this fit? Remember the order that we approach the fitting in. Even though we can see some staining here, little bubble here, the lens is riding low. What does that tell us? The main issue that you're going to address first is the lens is steep. I cannot see that feather touch that we're looking for with that determining the correct base curve. Here's another one. And what's our clues here? Slightly narrow band here, but that's really insignificant. If we look at where the lens is locating, it's locating down, which is distorting the fluorescent pattern. As I said, when you're judging the fit, always center the lens centrally over the pupil. That's so important for both the central fit and the peripheral fit. But the clue is here in the middle of this, here. What is that? That staining that we can see here. So we know that this lens is in fact flat. We would need to steepen the base curve. So I've already given you the answer there, unfortunately, but in this case here, it is the peripheral fit that we can see. How do we know it's the peripheral fit? Where's that fluorescent band? We've got bubbles trapped underneath the lens. The most common reason for bubbles is a tight peripheral fit. So if you have bubbles trapped underneath the central area, really reassess that peripheral fit and see if you can open it up somewhat. What is the first parameter you would change to improve this fitting? Think of the order that we've approached the fitting in. So what's the first parameter to change? You've got the base curve or the diameter, the edge lift. The first parameter that we're going to change is the base curve. This is flat. Immediately we change the base curve, two things are going to change. The lens will locate down further and we'll see this edge lift pattern reduce. So we can't judge this until we get this correct. So steepen the base curve. Probably in this case, you're also going to need to reduce the edge lift. As I said, you cannot judge that until you have the correct base curve on the eye. So what is the main problem with this fit? Lens is locating quite nicely. It's moving quite well. You have, again, 4 choices here. What's the main problem? First thing you can deal with is the base curve. It's a flat by about 0.1 to 0.2 millimeters. And as soon as we do that, that's immediately going to change the edge lift pattern and tighten it up a little bit. So probably by simply by changing that, I say, is the edge lift excessive? We don't know that until we get the correct base curve. So what I learned about keratoconus, the most common reasons for failure is number one, choosing the incorrect lens design. And the most common is choosing a corneal lens design for pellucid or choosing a keratoconic design for a nipple cone. Those would be the two that I see frequently mistaken. The edge lift is not correct and it's usually not sufficient. Ignored corneal astigmatism, we haven't had a chance to cover that today, but there is many asymmetric options which allow you to fit astigmatism with Rose K. Reluctance to vary the overall diameter depending on the size of the eye, how steep the condition is, the tightness of the lids, all those things influence the overall diameter that you need to choose. Number 5, are reluctant to use a larger semi-scleral design. If a patient has failed with a corneal lens before, then I will often immediately move to my XL design. And other things, poor lens maintenance is so important. You can do a wonderful fitting, but if the patient doesn't look after the lens, they will very quickly have issues. So a lot to cover there. We do have a very informative website here, and you can see at www.roseklens.com, if you go to the practitioners section here, there is both Rose K2 video guides which take you through all the designs, and also some downloads and fitting guides you can also download there. If you want to download the guides, you will need the password RKPRAC07. If you can't write that down, you forget it, you can contact your distributor or your laboratory to get that password. Sincere thanks to Menicon for putting this seminar together today. It's been very reinforcing to me to see how many people have actually joined us for this webinar. And I do hope that you have taken something away today that will be useful to apply in your practices just to help you be more successful with your corneal fits. Enjoy the rest of your day wherever you are in the world. Thank you very much.